Welcome everyone to our final Friday noon talk of 2021. Today we have the pleasure of welcoming Dr. Sarah McKenney. She's a diagnostic medical physicist at Stanford University and the lead physicist for the Lucile Packard Children's Hospital. She's the chair of the Pediatric Imaging Subcommittee and a member of the board of directors for the American Association of Physicists in Medicine, and is also a member of the Image Gently Steering Committee. So I will allow her to introduce her talk today. Thank you, Sarah.
Thanks for the introduction. So today I'm going to talk about a publication we had on which was a multi-institution consensus paper for the acquisition of portable chest x-rays through glass barriers. Just for some background, again, I understand there's a little bit of a mixed audience. So what's a portable chest x-ray? It's basically bedside imaging. It's intended for patients either in the emergency department or ICU who are unable to go to the radiology department and walk there and stand up for a typical chest x-ray. These patients typically are unable to sit upright and need a gurney for support. So this is what we use for imaging our COVID patients. The ACR recommends using chest radiographs when medically necessary. And that's really determined by if a patient is symptomatic or if they're already COVID-19 positive and we're monitoring disease progression and recovery. So this is not used for screening. I don't think it ever will be. We have our testing methods now, but we do use it for tracking our patients pretty regularly. So imaging through glass barriers was actually developed by University of Washington in 2014 in response to the Ebola outbreak. What this allows us to do is conserve PPE because you don't have to go into the room, and it reduces the exposure both of our staff and our equipment to any sort of bugs and contagious items. Since then, it's been implemented around the world. Here are just some publications from Utah, New Zealand, and in Canada, they did a cost analysis of this implementing this protocol. So you guys are involved too. At California, we wanted to implement this protocol, and we got to talking to our colleagues both at Kaiser Northern California and Southern California, and realized we had a lot of the same questions. So here are just some photos of the co-authors, and we had questions about, if imaging through glass barriers is great, but what about patient safety? What about staff safety? And what sort of techniques should we be using? The result of those questions and discussions is this consensus paper. So again, we operated independently. We did a lot of this investigation before we started talking to each other. So we had different experimental setups, but just in summary, it was 3 different healthcare systems, 5 facilities, and 6 radiographic systems that we evaluated. We had the same goals, which were to establish appropriate imaging techniques, evaluate patient safety, and to evaluate staff safety. So this is just an outline of the talk. I'm going to take little breaks and ask for questions in between each point, just to sort of keep you guys perhaps a little bit more engaged. We'll find out. Yeah. First, we're going to talk about transmission measurements. So glass is composed primarily of silicon, which acts much like an aluminum filter because they're atomically adjacent. A typical 1/4-inch glass will attenuate an X-ray beam by up to 60% with the same imaging techniques and geometry. And on the right, we just have a plot of X-ray transmission as a function of tube potential using the NCRP 147 model. And this is a report about shielding, and you can use different materials to estimate different transmission factors. So we basically performed our measurement in air and then compared that to the attenuation with the glass. We used fixed techniques for the transmission measurements. And so we have that same plot again of our transmission modeled out, but now I've included our data points. And what we have is a mean transmission of 39%. So the NCRP actually is a little bit more conservative and thinks, that we're seeing a higher transmission, which is really to be expected. All right, so based on transmission alone, let's say you're trying to do a quick implementation. If you want to simply match the entrance air kerma, you would increase your tube current time product, or what I've been calling mass, by a factor of 2.5. Okay, so any questions about that? I don't know. You would have to speak because I can't keep track of the chats. All right, let's just keep on rolling.
I can, if there are questions in the chats, I'll vocalize them.
Okay, thank you so much. All right, so what we looked at next was how do we match the dose to our image receptor? So as I'm sure many of you know, a glass filter hardens an X-ray beam, which leads to an increase in the effective energy and makes the beam ultimately more penetrating, such that a higher percentage of those X-rays are detected by the imaging receptor. So here's just a model of a 85 kV beam with no filtration. This red vertical line is the effective energy of that beam. When we apply the glass filter, a 1/4-inch glass filter, we can see that the overall fluence has decreased and that this dashed line here is the effective energy for this new spectrum, which is in blue, and we see that it has increased. So to look at the radiation dose to the imaging receptor, we used exposure index as a surrogate rather than another radiation solid state detector. Exposure index, just for a quick review, is used by technologists to ensure that their dose to their image receptor is consistent, because essentially both a large patient and a smaller patient, in terms of image quality, you want the same number of photons to be hitting the detector. So you would want to increase your technique for a large patient because that person is more attenuating to get the same number of photons and have a similar image quality. So what are our results? Well, just looking at beam hardening, again, at a fixed technique, the overall half value layer, HVL, increased when we made these measurements. And then at a fixed technique, our exposure index decreased. And in this case, it was reduced by an average of 32%. So just as a reminder, we saw transmission reduction at the patient entrance of 39%, leading to us to scale by 2.5. But if we actually look at what's hitting the detector, it's more of a decrease by 32%, so slightly less. And that leads to a scaling factor of 1.6. So we actually don't need quite as much output as we originally thought if we look at what's hitting the detector. So any questions about that?
I don't know if you're going to get to it, but do you also have to change the SID dramatically because you're now outside the room?
Yes. So SID, so this was also performed at a fixed SID. I'll be talking about that, but you do have to also scale by the SID for this to work out. And many times it is different than what you would typically be doing.
Right. I would assume you'd have to be a little bit further away because you're now behind a glass barrier.
That's exactly right. Yeah. Okay, so moving along. Then of course you got to look at image quality, because you can't just be messing around and filtering beams, and if you have to see if the images are still diagnostic. So there's no standard radiographic image quality phantom. We just, for this study, looked at the contrast to noise ratio. which for a quick background is just simply looking at the difference between a signal and the background and then dividing by the standard deviation of the background. And these phantoms are basically whole plates with holes of varying depths drilled into them. So we looked at this for each hole. And these are our results. So in blue, we have our original no glass barrier results standard technique. And these different data points correspond to holes of differing depths. In red, we have the new technique, and this is actually performed with a scaling for a matched exposure index or image receptor dose. And what we can see is that it depends on the system. For one system, the CNR was comparable. On our AGFA, we actually performed a little better before we had the glass barrier. And then at the Canon system, we actually performed much better with the beam filtered. So it's a little bit dependent on the system you have. But overall, what we decided is this is roughly comparable. And so just for a qualitative look, here we have on the left an anthropomorphic phantom without glass at a typical technique. And then on the right, we have the same phantom with glass with that increase in tube current time product. And when we talked to our radiologists, they said that the image quality was acceptable. At Stanford, ultimately, they actually decided this wasn't quite enough. And I think you can kind of see a little bit of cloudiness here compared to there. And so we tried moving towards matching our entrance air kerma and doubling our mass to ensure adequate image quality. So any questions about image quality? All right, I'm just going to keep going. All right, so we next looked at patient dose, patient effective dose. So we performed these estimates by first using our entrance air kerma measurements. We then, instead of using, we used a more standard scaling factor determined from that NCRP curve I showed before to account for the attenuation of the glass. And then our effective dose was estimated using Monte Carlo software called PCXMC. This uses the ICRP 130 methodology for estimating effective dose. So for the people who are more therapy oriented, this might be like just so rudimentary, but this is how, this is our tool in imaging for estimating effective dose. And what we did was we used Spectre 3.0 as well as our HVL measurements with and without glass and tube potential to estimate the inherent filtration of the unattenuated beam as well as the thickness of glass for the attenuated beam. We then plug those values into our Monte Carlo software to estimate our patient effective dose. So here's just our plot. This is our original tube current and then scaled for that 60% transmission reduction and our resulting effective doses without the glass and with the glass. Again, this time we're not using a fixed technique. With the glass, we have an increased tube current time product. And overall, we have a change ranging from 4 to 10% in our effective doses. And what we concluded from that is imaging through glass minimally changes patient effective dose, despite the fact that you're could feel like you're dramatically increasing your mass. So what's not shown is the effective dose at a fixed technique, you're seeing a reduction of 50 to 80%. Due to the decreased entrance air kerma and more penetrating beam. When we increase our technique, we're seeing a small increase in our patient effective dose under 10%. Just for a frame of reference, this increase is of the magnitude of 1 microsievert or 0.06% of the average annual exposure to background radiation in Canada. And I really have to credit Matt Waite for making that Canadian-centric calculation. But that's just to provide some context. All right, so any questions about patient effective dose? All right, we'll just keep on plugging along here. All right, so staff safety. We use scattering phantoms and at different phantoms at different facilities. So here at Stanford, we used an anthropomorphic phantom. At Kaiser, Northern California, they actually used a 32 centimeter CTDI phantom. And we all made scatter measurements at different positions. Actually, this picture kind of shows we made these measurements, I think, right in March when the pandemic was just starting, and no one was wearing masks yet. We didn't know, but we were wearing gloves because we didn't really understand what we were doing. So anyway, so that we made these scatter measurements, normalized them then to standard measuring points. So here are our results here. And what I want to just emphasize is that we also provided, these are our average scatter measurements, and we converted them into an allowable number of weekly portable chest x-rays. This is because when we were implementing this protocol, there were actually a lot of concerns from staff members about their safety. And there was a reluctance, of course, to adopt this new protocol without understanding what sort of risks were associated with this protocol. So just to look a little bit closer at our results, this is a diagram showing our standard measurement points. And in red, I've just highlighted the areas that ended up having a little bit higher scatter. And that's because we have two sources of scatter in this geometry. We have both our patient, but then we actually have a spray of scatter coming out from the glass barrier. So what this means is that if you're behind the gurney or behind the glass actually is a protective barrier from the patient scatter. And in those areas, you can perform quite a few weekly chest x-rays. And of course, if you're 3 meters from the tube, you know, this is never happening. Thousands of weekly chest x-rays can be performed. And just as a reminder, this weekly allowance was determined from the public limit of 0.02 milligray per week. So this slide comes from Virgil Cooper, and what they did at Kaiser, which really helped with the adoption of this protocol, was to provide the information which were postings within the ED. So they provided a map of the patient, the tube, and sort of what sort of number of chest x-rays were acceptable on a weekly basis, and along with some information about how these measurements were performed. This did a great job of reducing the anxiety of the folks who were adopting the protocol. And they were actively involved with sort of creating this map and info sheet. I think this is really can be a great concept that can be expanded to any new protocol. A lot of times we make efforts to educate our patients, but it's really essential, especially when adopting a new protocol, to also, or workflow, to educate our workers and frontline workers in particular. So in summary, with the staff measurements, they interviewed the personnel within the emergency department to make sure that they were creating meaningful information, and then conducted measurements in terms of portables per week. This allowed staff to, in a sense, track their own radiation exposure and based on the maps posted. Again, it was important to provide easy, transparent information. A staff member understands a number of chest x-rays per week rather than a certain milligray of scattered radiation. So it really led to a quick and widespread adoption of this protocol. Okay, so before I talk a little bit more about implementation, any questions about staff safety?
So there's one question in the chat. It asks, were staff wearing lead apron during the chest x-rays?
Oh, good question. So I guess typically for portable chest x-rays, our staff, our technologists do wear lead aprons. That's sort of just our protocol all around. Depending on how this protocol was implemented, there would either be a person in the room or not in the room. And we did recommend shielding for our staff if they were within the room. It also depends a little bit on the room geometry. Some of these isolation rooms are quite small, so I can show you some photos in this implementation area. Any other questions before I move on? All right, let's just keep going. All right, so I'm going to just talk about the workflow. Again, you need buy-in from the emergency department and nursing leadership, because at least at Stanford, we worked with nurses for this technique. Again, we needed lots of education and making sure that there was an understanding of the workflow before it was actually implemented. It took a whole team, and I think if you were to implement this at your own institution, you need technologists, physicists, and radiologists all working together to make sure that the image quality is acceptable. And actually, when we first rolled this out for the first month, every single portable chest x-ray through glass was being reviewed by a radiologist, and that's how we came up with some of our tweaking with the output. So this is the cassette handoff. So basically we have a technologist, I'm sorry, on the outside wearing masks and gloves, but not like a full isolation gear. And they hand off the cassette to a nurse who is in the room with the patient. They double bag the cassette just to prevent, to reduce the need for cleaning, and it's just slipped through the door. Actually, this should be the nurse. The nurse brings the gurney as close to the door or glass barrier as possible. And this kind of addresses Pete's question. This reduces our SID. And then at Stanford, we had actually extra rolling lead shields, and the nurse would stand behind the lead shield during the exposure. I also want to emphasize that we brought the X-ray tube as close to the glass door as possible as well. This had a two-part advantage. Of course, it reduces our SID to something that's more typical, but then also the tube itself intercepted a lot of the scatter from the glass door because, you know, it's an X-ray tube is a lot of lead in addition to being an X-ray tube. So in fact, we found at Stanford a reduction in our operator technologist scattered radiation dose with the glass barrier, because again, the glass was protecting them from the scatter from the patient, and it was also the X-ray tube was protecting them from the scatter from the X-ray field incident on the glass. If you guys are interested on the workflow, we have created some slides with the Society of Thoracic Radiology, and it's in different languages for different folks, just because there was a need for adoption at the time. All right, and this is just the basics of how this is implemented. So how do we, you know, if you want to quickly implement this at your institution, what do? You take your old, your standard technique value, you scale it by the transmission of the glass, and then you also need to scale that value by a correction factor for the inverse square law from a change in your SID. We want to make sure that we're accounting for both the transmission, the changes in transmission, and geometry. And all this does is ensure that we have the same entrance air kerma exposure. This doesn't account for what would be hitting the detector. So it's EA key scaling rather than EI scaling. So just looking at the transmission factors, this is essentially the inverse of the NCRP plot that you saw before. And we see that we need more scaling if you use lower tube potential values compared to if you use a higher tube potential value at your institution. So anyone can do this. You just got to know what your current technique is. Similarly, we corrected for the inverse square law. This is in inches here, but if you're able to maintain a 72-inch SID, then of course no corrections necessary. For the most part, the SID is going to be higher and you're going to need to increase your output. So for example, at Stanford, we actually also support the VA, and their SID was more along the order of 10 feet. And so in that case, we actually needed to increase our output by a factor of 2.78 or over 2.5, simply for the change of SID. That doesn't even include the scaling factor for the attenuation of glass. So again, that was scary for our technologists at the VA to essentially increase their techniques by a factor of 4. And that's why you have to be in constant conversation, because what ended up happening is sometimes techniques were not increased in that amount, and then you have these non-diagnostic, really grainy images. So this is just a quick example for our students here. If we have a facility that typically performs its portable chest x-rays at 95 kV and 3 mass with an SID of 72 inches, we found that in our institution, the SID increased by 1 foot to 84 inches. And what should the new mass be? And so what you simply have to do is look up your scaling factor for the attenuation of glass for 95 kV, correct for this increase in SID. And we have a new proposed mass of 8.5. And so again, you have to kind of be confident and communicate this with your technologists that you're going to see this increase in mass. And that's what you need, just to simply match your entrance air current and have a similar image quality. So that's it for what I'll be talking about today. I just want to acknowledge our frontline workers, as well as our technologists and radiologists. And in particular, I want to acknowledge Kalpana Kanal at University of Washington, who helped us with our implementation and spearheaded that work at University of Washington. I'd also like to just acknowledge the friends and family lost during the pandemic. And, you know, this is what motivates us to do this work and innovate. So thank you. Any further questions?
Great. Thank you so much for that very interesting talk. There's one question right now in the chat. It's related to the lead apron question from before. So the question is, so the staff limit in terms of number of x-rays you can perform in a week, was that based on wearing or not wearing an apron?
That was actually based on not wearing an apron. So
so it's a conservative
yeah, it's a conservative estimate, and it's really a lot of the anxiety comes from nursing staff. I'm sure you see that on a regular basis. A lot of my frame of reference is with pediatric imaging, but in peds, typically a nurse might be recruited to hold a patient for an x-ray. And, you know, they get recruited a lot. And they're not necessarily tracked just because they're switching so often. So we just did a worst case estimate.
That makes sense. Great. Yes, so if there are any other questions from the audience, please feel free to either type it in the chat or unmute yourself and ask.
So in the meantime, I'll just give a little bit of sort of where are we now.
Sure.
Interestingly, what wasn't anticipated when we developed this workflow is the fact that, I don't know how you guys are doing in Canada, but we have staffing challenges with our healthcare workers. And so the fact that this is sort of, we're conserving PPE, that was the motivation. And at the time that was essential. I'm sure you guys all remember having masks and paper bags and saving them. But at this point, the limit is more personnel than PPE.
Right. So do you actually have a this was going to be a question I had. How many people does this technique now reduce from both being in the room with the patient and then just total? Does it actually reduce the number of personnel required?
It doesn't reduce personnel, it just reduces PPE.
Right.
So, for example, the masking and the gowning, that was a big issue, at least for us here.
Right.
And so our nursing staff sort of stuck with that. And our technologists then didn't need that, and from working on the outside. But no, I think pretty much anyone can get N95s. And
yes. Yes, it was a bit sparse at the first few months.
Yeah. And now the question is, like, can we get enough technologists to man all the X-ray rooms and, nursing staff to care for our patients? That's the limit. And this doesn't address that.
Yeah, we have a similar issue here in Quebec. It's hard to keep people.
Yeah. Another question I've received in the past was what do we, is this possible with prone patients? So those
Right.
patients that have a more severe case of COVID, and it doesn't work for that either. So in those cases, you do still have to go in the room.
Right. Is it, in terms of positioning the patient, is there a significant amount of difficulty bringing the tube outside, like in terms of getting a good oblique incidence? I guess you're just a little bit further away.
Yeah, it's a little bit of a different workflow. I think a lot of times with the portables, they're really doing more like an over table type shot. So I think so for us at Stanford, at least, with this oblique configuration, we do not image with a grid. I don't know. Do you guys do portables with grids in?
I know that we have a lot of DR portables, and they have there's some that have a grid installed in it. Now I don't know when they do and do not use this, but I know there are gridded portables being taken.
Yeah, I mean, if you look at these images, you're looking for sort of like a subtle cloudiness, which indicates, oh shoot, I don't have the clinical images in this presentation. But you're looking for opacities and things like that. And so the scatter does reduce your contrast to noise ratio, particularly in larger patients, which is part of why we had to up our technique. And but we also were getting just grid cutoff.
Because of you're at an extended SID.
Yeah. And again, just sort of matching the grid to the X-ray tube.
That would probably be a worse detriment to the image quality than the actual scatter, I bet.
Yeah, exactly. Yeah, Gary Barnes, I actually spoke to him. He has some interesting alignment tools for portable chest X-rays just to address this.
Oh, yes.
And maybe one day we'll see that, because it would be great to, guess who's preferentially, in the hospital with COVID. It tends to be more severe for our larger patients.
Right.
And these are the people who maybe aren't getting as high a quality images. So it would be good to see that happen.
Yes, certainly. Okay, any questions? Have you had a chance to think a bit more? I was going to mention when I introduced you, it's nice to have a speaker who is a diagnostic imaging physicist, such as myself. Typically, we're either getting talks from therapy physicists or people who are doing purely research. which tends to be related to radiotherapy. So this is, I mean, this is a nice demonstration of the kind of work that can be done in an imaging position. So I'm excited about that.
Yeah, we do very cool stuff.
But
I would say that imaging is just as life or death as therapy. You know, if we can't diagnose something or if it's missed, that's bad news.
absolutely.
So
And here
yeah, I'm a fan of imaging too.
the dose isn't to, it's not about giving a dangerous amount of dose for treatment. It's to keep the amount of dose as low as possible while
Yeah,
still getting an image that has all the information that needs to be there.
that's right. It's the more of a subtle and refined sort of motivations and long-term thinking and yeah.
It's more
Oh, I'm
delicate.
curious. Yeah, curious with you guys. Speaking of doses, so have you heard the new controversy about tracking cumulative effective doses?
Sure, especially for CT.
Yeah.
So actually, this is not for our McGill speakers, but in the Comp Imaging Seminar Series, we have a speaker in April who will be addressing this issue of cumulative dose tracking. And I'm interested to listen to it. So it is for people in the audience who aren't aware, it's a bit of a controversial thing. Is it detrimental actually to track the cumulative dose patients receive from imaging, in that it might scare people away from taking an image that could potentially save their life just because they're worried about the radiation dose? So yeah, that's a hot topic.
But then there's just so many other, I've had so many interesting discussions. Yeah, it's a super hot topic and very polarizing and interesting. But in therapy, in fact, a lot of this image guidance, you now see patients that receive maybe 30 CT scans or onboard imaging systems, and dose calculations are so carefully estimated, but I don't think imaging is part of that equation. So
that's right. Yeah, I know. I've seen studies that show that over the course of radiotherapy, these patients are receiving many hundreds of millisieverts of imaging dose that doesn't get accounted for in their plan. So
yeah.
So we actually have two questions here.
Okay.
We have says, thank you for the very interesting talk. I'm wondering if the refraction of the X-rays by the glass is a considerable factor at all for image quality.
Oh, that's a good question. We didn't see any sort of X-ray refraction, but that would be more of, I think, something that'd be observed through high resolution MTF sort of analysis rather than contrast to noise. Yeah, that's a good question. I can't answer that. I would say probably not, because again, glass is very similar to aluminum, and it's pretty common to use aluminum filters for beam shaping. So I don't think it's anything significant at all.
I think this comes down to just physics of electromagnetic radiation, where our wavelength is way too short. So the index of refraction is relevant for optical photons. But yeah, once you get into the KeVs for photons, I mean, the concept of what do you call it, the permittivity of the beam and the index of refraction now becomes moot because now you're ionizing. So
yes, yeah, yes.
Actually, whoever asked that, that's a good PhD prelim type question.
That's a good physics question.
And there's one other question here. What do you feel were the advantages that this new technique brought, and any disadvantages?
Well, again, at the time, the advantage was really, reduction of staff exposure to COVID, which we didn't really understand. And these were frontline workers working with our COVID positive patients, as well as PPE conservation, which again was something else. Masks were under lock and key. And so those were very real needs at the time. In terms of disadvantages, we needed extra shielding for the person who would be staying in the room. So it's not necessarily feasible for everyone. And if you're running inside and outside the room to perform this and having to gown up, you're not really conserving PPE, and maybe you're saving time because you don't have to clean your portable X-ray, but that's about it.
All right. So that's perfect. If there's no other questions, I'd like to thank Dr. McKenney again for an excellent talk. And this is our last noon seminar up until next month. So, oh, hold on, there's one more question. Are they still using this technique?
Oh, so I asked. So at Stanford, we've had about 3,000, I think 3,000 plus portable chest X-rays performed through glass barriers. Again, it's not used consistently. It's really dependent on staffing, but essentially everyone's familiar with it. So if there is a nurse there, they're using this method. If they're not doing it. So they're bringing the X-ray into the room. Or actually, I think they're bringing it into the room. So it's sort of a 50-50. So their initial adoption was really high and now it's kind of trickled down, but they're still using it, just not consistently.
Okay, fantastic. All right, so thank you. And thank you to everyone who attended, and we'll see you all in 2022.
Yeah, thanks again for the invite. Happy holidays.
Hopefully, hopefully when traveling becomes a little easier, we can host you here in person next time.
Oh yeah, wonderful. Yes.
Not in the winter though. It's not as nice in the winter as California.
There'll be a shock for a Californian. Yes.
All right. Thank you so much.
Thank you. Bye.
Bye-bye.